So we present a 60-day-old male infant who was referred to our hospital with rash for investigations. So the mother claimed that the baby was born with this rash. The rash started initially on his face, then it went down to the upper trunk and extremities. It was sparing the back and the genitalia. The rash was purplish in color with varying sizes. The largest lesion was almost pea-sized, and it was over his right thumb. The rash was raised as well. Some lesions had involuted spontaneously. There were no aggravating or relieving factors, and there were no secretions, itchiness, or oozing, and no similar conditions in the family. So by further questioning, the mother denied any history of jaundice, easy bruising, fever, irritability, or abnormal movements. There was no decreased feeding or lethargy, no eye discharge. The patient had no URTI symptoms, no abdominal distension with unchanged bowel pattern, and there was no joint swelling as well. So the baby is a product of his full term. He's a product of cesarean section due to fetal distress and prolonged labor. There was history of PROM for more than 18 hours. His birth weight was 2.5 kg. He was on the 3rd percentile weight for age. The infant was admitted in the neonatal ICU in the referring hospital for 27 days for diagnostic workup only, but he was clinically stable and did not require mechanical ventilation. He had blood transfusion twice due to his anemia. The mother denied any history of severe jaundice or phototherapy during his ICU stay. The mother was primigravida. She had no previous abortions. She had URTI, mild urinary upper respiratory tract infection at the 2nd trimester and burning micturition at the 3rd. She was booked and followed up regularly during pregnancy. GPS screening was not done. There was no maternal history of rash, intrapartum fever, or sexual transmitted disease. There was no consanguinity between the parents. The mother is 27 years old. She's from Yemen. She's a housewife with high school degree, and she's known to have iron deficiency anemia on iron supplements. She's fully vaccinated. The father is 26 years old. He's Saudi. He's a soldier and is medically free. There were no similar conditions for this rash in the family, and there's no family history of chronic illness, hematological disorders, gallstone removal, malignancies, or early death. So by going to the physical examination of our patient, this was our patient when he presented initially. The baby was, and he had this rash. So the baby was conscious and alert. He looked well. He was not in distress, and he was well hydrated, not pale or jaundiced. He was vitally stable, and as per the anthropometric, and he was afebrile. As per the anthropometric measures, they were all within the normal range. His weight was 5 kg, which was on the 50 percentile. Height was 56 centimeter on the 50 percentile length for age. Head circumference was 38 centimeter on the 50 percentile head circumference for age. As for the systematic examination, there were, as you could see here, there were multiple non-tender and non-adherent purplish blue papillonodular lesions. They were firm, non-mobile, non-blanchable with smooth surface. There was intact overlying skin, and some lesions had irregular margins as this one. The lesions were of varying sizes, ranging from, as you could see here, 0.2 into 0.3 centimeter to 2 multiplied by 2. The lesions were mainly in the upper body, in the upper trunk, the face, and the upper extremities. There were no oozing or secretions. And I would like to stress on that the patient had no lymphadenopathy, he had no hepatosplenomegaly, and he had intact red eye reflex. So we call this rash that the baby had as a blueberry muffin rash. So in summary, this is a 60 days old Saudi male, full term, with 27 days of ICU admission. He presented to our hospital with congenital blueberry muffin rash. He was vitally and clinically stable. Mother was booked during her pregnancy with normal follow-up and investigations. So when we saw the patient for the first time in our hospital, we thought of, we had the following differential diagnosis for the blueberry muffin rash that the baby had. Our first differential by then was the congenital torch infection, and we also thought of the hemolytic disease of the newborn, in particular ABO incompatibility. Our third differential was infantile hemangioma, leukemia cutis, Langerhans histiocytosis, and finally congenital neuroblastoma. So we investigated those differentials. So before moving on to our investigations, I would like to share with you a roadmap to approaching the blueberry muffin rash. So at first, it's crucial to rule out the torch infections, the congenital torch, as it is the commonest cause for this blueberry muffin rash, by doing the maternal and newborn viral serology screening. And then we're going to do the basic lab workup, CBC looking for anemias, any leukopenias, liver function test, and inflammatory markers. And then the cornerstone, which is a skin biopsy for histopathology. And then you're going to do also bone marrow aspiration if there were any findings that were worrisome for malignancy, radiological investigations in case it was either torch or malignancy, because we want to rule out the complications for torch infection and any metastasis if it was malignancy, and PET scan if needed. So our first differential was torch. So we did the virology screening for the baby, and it was unremarkable. And then, so congenital torch infection was ruled out. So we did the CBC with differentials to investigate for the hemolytic disease of the newborn. And in here, as you could see, the baby had microcytic hypochromic anemia with high RDW. This could have been, by then we thought it could be due to the iron deficiency anemia that his mother had. And the baby also had like the leukopenia. Liver function test and renal function test were all within normal. Ferritin level was normal as well. So we're still investigating for the hemolytic disease. We did a direct Coombs test. It was negative. The baby blood group was O positive. His hemoglobin electrophoresis was normal. Peripheral blood smear showed pancytopenia. So now we did the mother's, so we went now to the mother and we investigated her. Sickling test for her was negative. The mother had O positive, blood group was O positive. So now we could exclude the ABO incompatibility as both the mother and the child are O positive. Peripheral blood smear was normal as well. She had hypochromic microcytic anemia with high RDW, and this explains her iron deficiency anemia. So now I would like to give 5 seconds for the audience to answer this question about the gold standard test for diagnosing neonates with cutaneous nodules. So the answer is the gold standard test is skin biopsy in cutaneous metastasis for the babies. So now we excluded hemolytic disease of the newborn, and we went down to investigate the infantile hemangioma, leukemia cutis, and Langerhans histiocytosis. So we did the skin biopsy for the immunohistochemistry, and you know that it took like almost 2 to 3 days to come out. Meanwhile, we did brain and abdominal ultrasound to rule out any visceral involvement, and it was unremarkable. And then we did bone marrow aspirate as part of the leukemia cutis and Langerhans cell workup, and it was unremarkable as well. So by then, the skin biopsy result has already came, and it showed Langerhans cell histiocytosis. So we made a diagnosis of this. And then as part of investigating the Langerhans cell histiocytosis, we did brain MRI with contrast to rule out any CNS or skull metastasis, and we did the skeletal survey to rule out any bone involvement, as well as urine osmolality, because diabetes insipidus, it is the most common endocrinopathy associated with Langerhans cell histiocytosis, and luckily they were all negative. So we came out with a conclusion of single cell of a single system cutaneous LCH. So these are the most common differentials for the patients with blueberry muffin rash. So we need to think of congenital infections, and the most common in congenital infection is cytomegalovirus. And again, there is rubella and toxoplasmosis, and these are the most common infections that present with this blueberry muffin rash. You need also to think of severe hemolysis, such as ABO incompatibility. As you could see here, this was a reported case of an infant with blueberry muffin rash, and he was found to have ABO incompatibility. We need to rule out also neonatal malignancies, such as neonatal leukemia or leukemia cutis. You need to rule out, this is a term baby who was born with this congenital blueberry muffin rash. He was found to have rhabdomyosarcoma. However, he did not make it, and he died at the age of 1 month. We need also to think of the congenital vascular lesions, such as hemangiomas. So blueberry muffin rash, it is produced by the extramedullary hematopoiesis. This term originated in 1960 after the rubella epidemic. So as mentioned previously, cytomegalovirus or cytomegaloviral infection, it is the most common congenital torch infection. However, the cutaneous involvement is less than 5% of cases. Another common cause is congenital neuroblastoma. And congenital neuroblastoma, it is the commonest neonatal malignancy. And again, the cutaneous lesions here only appear in 1/3 of cases. So you need to have high index of suspicion. Okay, so usually in congenital neuroblastoma, it has some characteristic appearance that when you rub the lesion, it produces a halo, and this halo stays for 30 to 60 minutes until it resolves. In our patient, we did this. We rubbed those lesions. However, we did not observe this halo. So by this sign and also by the investigations, we ruled congenital neuroblastoma. This was a study that was done by Isaac in 2011. He investigated the cutaneous metastasis. He investigated the cutaneous metastasis in the newborns. So in this study, he recruited 208 neonates with cutaneous metastasis. And out of these, he found out that the most common dermatological manifestation in these malignant tumors was the bluish nodules or the blueberry muffin rash, and it appeared in 82% of the 208 babies. So then he ranked those malignancies. He found out that leukemia and multisystem Langerhans cell histiocytosis, they had the most favorable prognosis. In contrary to rhabdoid tumor and rhabdomyosarcoma, they had very low survival rates of 4% and 15% of the rhabdomyosarcoma. The overall survival rate, unfortunately, is low, which is 39%. That is why you need to have high index of suspicion whenever you see neonates with this blueberry muffin rash. So going back to the Langerhans cell histiocytosis, basically this cell is produced. These cells are produced by the inflammatory myeloid hyperplasia, and it is rare. It appears like 2 to 10 cases per million in children who are under the age of 15 years annually. And it appears in all age groups from neonates to adults, but it is more common in children, especially in those in the infantile group who's ranging from 1 to 3 years old. And there's male predominance, which is 1.3% as compared to 1 for the females. Langerhans histiocytosis, it could affect multiple organs. It's not confined to one organ only. In a report that involved 1,741 children, they found out that bone and skin, they were the most common involved organs, making 77% and 39% respectively. However, as you could see, there's also multi-organ involvement, and CNS, which is the most critical organ to be involved, was the least. Usually, lung involvement is seen in older adults, and usually it is we see it more in those in the smokers. So, as I mentioned previously, and as in our case, Langerhans histiocytosis, most of the times it's limited to one organ system only in 55% of cases. The rest of the patients, they could present as multi-system disease, and this is most often seen in children who are less than 3 years old. So again, this is a question for the audience about the first-line treatment in single system, Langerhans histiocytosis with limited skin involvement. I would like to give you 5 seconds to answer. So actually the answer is cautious observation in case if it was cutaneous Langerhans histiocytosis. So as for the skin manifestations in this disease, it could present in multiple pictures. It could present as papules, as you could see here. These are brownish to purplish papules, and they could appear in any part of the body. Usually those papules, they are self-healing, and we call them reticular histiocytosis. Or it could appear as a severe eczematous rash that could resemble a candidal diaper dermatitis that is prolonged and not responding to treatment. Or it could present as severe and prolonged radial cap as well, and in older patients, seborrheic dermatitis. So again, it is prolonged and it does not respond to treatment. So we need to think immediately of LCH. So usually patients who have skin-only disease, they have favorable diagnosis, and these lesions, they are usually self-healing. However, there's no prognostic factor to predict the course of the skin disease only. As I mentioned, this disease is really rare, and most of the investigations or most of the medications is taken from the clinical trials. So 40% of infants, they could progress to multi-system involvement. So if the disease was in a limited surface area, then you could do watchful observation. However, if the cutaneous disease was symptomatic, and I mean like the patient complained of pruritus, or if there was extensive skin disease, as in our patient, then the choice is topical steroids. If there was no improvement, you could go to other lines such as hydroxyurea, methotrexate, and so on. But the number one treatment is topical steroids for cutaneous disease. So whenever you treat a patient, before starting managing a patient with LCH, you need to ask yourself 3 questions. At first, is there any critical or risk organ involvement? And what I mean by critical is the CNS and lung. And risk organs are the liver, spleen, and bone marrow, because by then you're going to require systematic therapy. Is this disease single system or is it multi-system? So in single system, usually, as I mentioned, you're going to treat the patient with topical steroid. If it was in the bone, you could do curettage. Or is it multi-system? I mean like 2 or more organs are involved. And then is this disease unifocal or multifocal? And usually this question is asked or this subclassification, we use it in the bony involvement. So unifocal if only one bone, and multifocal if more than one bone was involved. So as for the post-treatment surveillance, a retrospective study that was published by Minkov in 2008, he studied 335 patients with multi-system LCH that had achieved complete response to treatment. So he followed them after 2 years, and he found out that sadly 50% of them had the first reactivation. However, they were fortunate enough that there were only 3 deaths, and 10% of them only had risk organ involvement. 85% of the patients responded again to their treatment. He followed them again after 5 years, and 44% of those patients had their second disease reactivation. So reactivation in LCH is frequent and early event. However, involvement of risk organs and mortality are minimal. So So going to the isolated cutaneous LCH, usually we assist those patients every 2 to 4 weeks until they're stable or the lesions have resolved. So we pay special attention to the following signs that could suggest metastasis or generalization of the disease. So we need to check, is there any failure to thrive? Is there any pallor? Is there any bone pain or swelling? Is there diabetes insipidus, organomegaly? So after complete healing, you need to follow the patient every 6 months for at least 5 years. So this is our patient. We followed him up every 2 weeks and we treated him with topical 1% hydrocortisone. So that was after 2 weeks of the topical treatment. After 3 weeks and then here after 2 months, you could see that almost 90% of the lesions have resolved. So I'd like to say that skin diseases is not something to be overlooked. Almost 27 of the pediatric population visit to our ER and the primary health care are due to dermatological problems. And actually, like one out of 4 of the American population, they were impacted by skin disease. So it is really important to not to overlook these skin disease because they could hide something big behind them. So these are some common diseases as well that could mimic the blueberry muffin rash. So there's the Aicardi syndrome and also meningococcemia. These are some diseases that present with cutaneous lesions that have some multi-system involvement, indicating that skin could be as a tip of an iceberg, it could hide some organ involvement and these diseases could carry some worse prognosis. And then here the meningococcemia as well. So usually they present with skin rash and it is a fatal disease. So finally, I would like to conclude that although cutaneous blueberry muffin rash can be part of single system LCH, still it can progress to multi-system disease, necessitating prompt assessment and follow-up. So here, this is the tip of the iceberg. So you could see here, this is the blueberry muffin rash, which is the presenting symptom. And then down, there's the reactivation of the disease and the dissemination or the multi-system involvement. Thank you so much.